You have a patient that's been in the hospital for a while. Maybe they're a trauma patient, they've had several surgeries. They're in a lot of pain. They've required IV pain medications. They're on a PCA, which is this IV pump. You press a button and it delivers IV pain medications automatically. You've tried to transition them to oral medications and it didn't really work out very well. They were in a lot of pain, so you had to go back to the PCA. And I'll say the number one reason for failure there is when you convert from IV pain medications to oral pain medications. You need to take the patient's average 24-hour consumption, it's called the MMEs or millimorphine equivalents, and convert them from the IV to the oral medications and do an appropriate, dosage there, and try to mix up some extended release with some instant release if it's a patient that's been in for a while and has a big opioid tolerance. Either way, now they're back on the PCA. What do you do? What can you do differently? One thing you could try here is taking 50% of their MMEs and making it scheduled extended release opioids, and then you could take the other 50% and do PRN instant release. You may also consider, in bridging this gap, is a low-dose subanesthetic ketamine infusion to help reduce their opioid tolerance during this transition from IV to oral. A lot of research that suggests that a low-dose ketamine infusion can reduce the amount of opioids required for a patient. It can actually get them ready for discharge faster, right? It can get them off that PCA. And this effect can be a very prolonged effect and sometimes an indefinite effect, right? Either way, something to look at, and I'll drop in the comment some recent literature that suggests recommended dosage ranges.